Hello, everyone, and welcome to the podcast. My name is Dennis Cleary. I'm a senior researcher and occupational therapist at Cincinnati Children's Hospital Medical Center. Really pleased to be joined today by Dr. Laura Stimler, who is a faculty member at Spalding University in beautiful Louisville, Kentucky. How'd I do with Louisville? Pretty good? Okay, thank you, thank you. So we're going to talk about pediatric hospitalization, obstacles and opportunities for OT practitioners. And Laura, you're an expert. So could you just tell us a little bit about your background and sort of some of your expertise that has brought us here to the podcast today?
Thanks, Dennis. It's so nice to speak with you today, and I always enjoy opportunities like this, so thank you for having me back, OT.com. So first, I've been working as an OT since about 2002, and I started in the pediatric skilled nursing facility called Home of the Innocents here in Louisville, Kentucky, and I've absolutely fell in love working with pediatric medically fragile children in the hospital-based setting. And at that point in my life, I was ready to for a change of scenery, and I decided to move to New York City after working for about a year. But because I love the pediatric skilled nursing setting so much, I looked for a similar type of setting in New York City, where I found the Elizabeth Seton Pediatric center that serves a similar medically fragile population. So after getting about 4 years or so of working in that type of setting under my belt, I decided I wanted to switch gears and explore more critical care and just kind of dive into the role of OT in the acute care setting. So I learned about an available position at Memorial Sloan Kettering Cancer Center in Manhattan, and I happened to be in the right place at the right time because they were looking to expand their pediatric oncology rehabilitation programming. So I was so fortunate over a course of about 9 years to work with amazing mentors, Claudine Campbell, Mackenzie Perglotti, and others who collaborated with many other disciplines to help sort of establish and create a really solid foundation for a well-established pediatric program. So it was during my tenure really at Memorial Sloan Kettering that I absolutely fell in love with the pediatric acute care oncology population specifically, but really working with medically fragile children in the pediatric intensive care unit.
Great. So in terms of that, so these were kids that were coming in for surgeries, or they were coming in to get treatment, or what kind of kids were you seeing?
At Memorial Sloan Kettering, when I first started to work there, we had the pediatric observation unit. So that specific unit served children after surgery. So they came after surgeries for planned admissions, for close observation. It was also a space that was available for children who had very complicated medical conditions that needed to be more closely monitored. And over the years, the pediatric observation unit was transitioned to a true pediatric intensive care unit. So that was a really exciting effort to be a part of and watch come to fruition, because what started as a 3-bed pediatric observation unit was then transitioned to a 5 to 6 bed pediatric intensive care unit. So at that point, with the transition from, we called it the POO, with the transition from the POO to the PICU, the hospital was able to serve children really of all levels of critical needs. So as far as the PICU setting, we were able to keep children that required mechanical ventilation and just more intensive treatments that we otherwise previously would have had to transfer maybe to another hospital setting. So post-surgical care, close observation, many, many different types of issues.
Great. And these were kids, what was the average age, or not average age, but what was the span of the ages of kids that
It's
you'd work with?
interesting. In the oncology setting specifically, we serve children. The youngest patient I saw in the PICU was 4 days old, and that was a baby that was diagnosed with a very rare type of leukemia and blood-related issues. And in that setting, we treated up through young adults. And it's interesting in oncology, depending on the age of the child, if they have a cancer diagnosed in childhood, oftentimes as the same medical team will follow them for years and years into their survivorship. So we would often see older adolescents and young adults as well in that particular PICU setting. So a very wide range of ages.
Great. And I see from your bio that So you're now having some advanced degrees. So could you talk a little bit about that and what led you to get those more advanced
Sure.
degrees?
So while working in the pediatric acute care oncology setting, I decided to go back for a clinical OT degree that I earned at Rocky Mountain University of Health Professions, and I focused on their pediatric science track. And it was at that time when I did my capstone. I was really passionate about creating continuing education resources for OT practitioners specifically. And
You're in the right place
I
for
was
that
just
then.
telling a group of students I work with when I did my capstone in 2014, I had 6 articles that included the role of occupational therapy specific for peds oncology. And I really wanted to contribute to available literature to help guide therapists on how to manage a really specialized population. So I don't know. I can't say no to education opportunities. So here, I'm currently in the middle of my EDD program because with my recent journey to academia, I'm shifting gears a little bit and I really want to strengthen my personal research skills for personal and professional reasons, but also to support the students I work with in our doctoral program with their research efforts. So I really love to support publications and continuing education efforts, specifically in peds oncology, but really all of pediatric hospitalization.
Wonderful. And I'm sure you're bringing those resources to the classroom, which I know your students appreciate. Could you just talk a little bit about what are some of the greatest barriers to participation in occupations for children when they're in hospital, other than missing school, which maybe they like and
Right.
maybe they don't like, I
Yes.
guess.
So it's pretty standard for children, just, immediately when they're removed from their natural environment, of course, they're going to experience changes in routines and typical roles, and they have to accommodate, to a new environment. So when you go back to the occupational therapy practice framework and the beautiful long list of occupations, every single one of them can be checked as, being directly impacted for a child who's hospitalized. So it's a pretty global effect, but also when you think about the significance of the lack of predictability in a hospital-based setting, it can be overwhelming for everyone. And fear and pain are common issues, and they're frequently associated with many of the conditions that children are hospitalized for. Also, frequent transitions in care between hospital units and caregiver separation. So, there are a lot of things just related to the daily routine of being in an unfamiliar environment that can be overwhelming to everyone.
And then can you talk sort of the types of things that occupational therapy can offer to children and families during hospitalization?
Sure. So, uh, I always love to read the newly published workforce and salary survey published by AOTA. And in 2019, the trends are similar, but almost 30%, I think it's 28% of OTs work in hospital-based settings. So this, I believe, was a combination of pediatric hospitals, adult-based hospitals. But at the end of the day, it's the most common work setting for OTs. So knowing that, and also according to the Committee on Hospital Care, about 5 million children between the ages of birth to 17 are hospitalized annually. So as OTs, we're very well positioned to have a significant impact and play a pretty dramatic role in the experience of a lot of families. So some of the more common reasons for pediatric acute care hospitalizations are due to respiratory distress, including acute bronchiolitis, asthma, pneumonia, of course, COVID today, appendicitis, seizures, infections, dehydration. Other reasons might be traumatic injuries, different types of trauma, and other acute illnesses. And many of the children with these conditions are at high risk for secondary issues. So those might include things like decreased strength, compromised cardiovascular and respiratory systems, psychosocial concerns, emotional distress. So as OTs, we play a really important role in preventing some of those secondary issues. So helping to support families and, to help keep children active and engaged as much as possible in what would be their typical routine is really important.
Yeah, absolutely. So you're getting your Ed.D. and you have your clinical doctorate in OT. So you have an interest in evidence. So can you talk a little bit about how we can incorporate evidence-based practice when we're working with these, potentially really vulnerable children we're supporting?
Sure. So I think I've had experience working in departments that really prioritize evidence-based practice, and I've also worked in others that they're more worried about meeting productivity demands, and those priorities are really evident, I think on all levels. So some easy strategies that I've seen when working in programs that really prioritize building evidence into these fast-paced, complex, dynamic acute care settings are things like facilitating, an article discussion or a journal club on a monthly basis. Other activities are, presenting in services to a department or making it a priority to build time in the therapist's schedule for the OTs to attend in services in other departments so they gain a more holistic understanding of services delivered in the hospital and what's available to the children that we work with. And I just think in my experience when working in for institutions that really prioritize building evidence in what can feel like an overwhelming setting sometimes, it has a multi-layered impact. So first, of course, the children benefit, right? The client outcomes are improved. But I think it improves the morale of the program because as OTs, as we observe others, making it a priority for us to learn about what others in our profession are doing, it's going to make us want to do our best and practice best evidence. So I think it's little steps like that that can really help to create a high standard of care and develop this culture shift to a more evidence-based approach and set the bar high.
Yeah, and I know there's some really organizations that are really dedicated to the evidence-based practice, and in terms of even allowing some therapists to have part of their FTE devoted to that, and there's some that really incentivize and reward that to be able to have at least people on the team that have that as part of their paid role. And I think we're going to be talking about students here in a second, but just to put a shout out for especially OTD capstone students, are a phenomenal resource. I think one of the things, I used to be a fieldwork coordinator in a previous life and then also a capstone coordinator. And so fieldwork, it really is about helping the student kind of figure out how to be a therapist, and productivity is certainly a part of that. But within the capstone, there just is so much more freedom to really concentrate on some of those higher level skills, to give people a little bit more flexibility. I don't know if you're seeing that. I know you guys are transitioning at Spalding to the OTD currently.
Absolutely. And I am so happy you brought that up. You beat me to it. Please make room for OTD students in your practice. I'm speaking to the hospital-based therapists working in pediatric settings. And I know that right now, especially with COVID and everything going on, that, stricter isolation precautions and visitation requirements are more rigid. Students, it can be such a win-win for all involved. And in working with the students at our university, we really embrace community-based practice. And for those, I am partnered with many students who are interested in rehab oncology specifically. So right now, especially during COVID, it's incredibly difficult to establish partnerships with institutions that are National Cancer Institute approved hospitals that are providing active cancer treatment because, regulations are so strict right now. So as a way kind of around that, and to set students up for a really rich capstone experience, we worked closely with more community-based partners to help build sort of bridge programs and to help and just to focus more heavily on reaching this population specifically in different community-based settings. But I think capstone students are a fantastic way to build programs that are evidence-based while the students are very, closely supported by faculty who have a research interest in that area too. I think another benefit to partnering with a capstone student is that closer relationship with the university oftentimes offers and affords a hospital-based setting more resources as far as just peer-reviewed journals and databases and that sort of thing. So that can be a really exciting collaboration for all involved.
Yeah, and I know at Cincinnati Children's we're doing our best to try to support as many capstone students as we can. I know I actually have two right now. That's how much I care about
That's
this,
great. That's
and I think when
great.
we help have students that expect that they're going to be using evidence in practice, that that's going to continue after they graduate, and this next generation of therapists that are going to be caring for me when I'm old. So I appreciate that. Can you just talk a little bit about like formal standards or guidelines that OT practitioners may use in terms of bringing evidence-based practice to hospitals, specifically for psychosocial needs or other needs, especially for these kids that are really sick?
Sure. And I think over the years, we've seen many guidelines emerge regarding specific conditions and that are very, tailored to meeting children and families where they are during different points of care. So one example is the National Comprehensive Cancer Institute offers pretty helpful guidelines on phases of care that might require closer observation to meet psychosocial needs and assess psychosocial needs. So they are very specific in identifying times that children and families might be more vulnerable to experiencing emotional distress, um, and even post-traumatic stress disorder after certain types of treatment and experiences in the hospital. So that's one example of many. The American Academy of Pediatrics Committee on Hospital Care also offers pretty specific regulations and standards with how to interact and utilize certain disciplines and certain interprofessional collaborative efforts. So AOTA, actually, I really like their recent publication on addressing acute stress and trauma, the decision guide that they posted in response to COVID-19. So I think AOTA, if you look on their website and kind of, search different specialty topics in pediatric hospitalization, they offer a pretty significant amount as far as decision trees and how to navigate different complex issues that are timely, including COVID. And I would like to speak to sort of a couple other issues. And I think one thing that can be so overwhelming and complex about the acute care environment is the medical complexity and the impact that lab values and the lines and tubes and all the levels of everything involved. It's kind of like, where do we start? So I've had really I've had really unique experiences working in the oncology setting where oftentimes we sort of look to, not sort of, we do look to nursing standards and activity parameters established outside the scope of OT. And I think it's unfortunate because sometimes when those standards or guidelines are not well understood and when they're broad, people tend to be very conservative in what they do with patients. So when we think about kids in the hospital, I think it's really important that OTs are confident and advocate on behalf of the kiddos we work with who are especially at risk for issues related to immobility. So an example I'll share, I was part of a retrospective research study, and we looked at children admitted for stem cell transplantation that were diagnosed with thrombocytopenia. And we wanted to see if there were any associations between activities in occupational therapy.
Now, I just want to say, I'm sure everyone out there knows what thrombocytopenia is, but would you just describe that
Sure,
quickly?
sure. So it's low values of platelets and hemoglobin in different blood levels that put patients at risk for bleeding. So oftentimes and the many times, the actual definition of it or the level, it may be, hospital or institution specific. So when children present with these specific blood levels, often, a decision is made to just hold therapy. And that can be really detrimental to kids who are in bed all day. So we wanted to look to see if there were true associations between occupational therapy activities and the occurrence of bleeding adverse effects. And we didn't find that those were not commonly associated as impacting each other. So my point is, I think as a profession, it would definitely be in the interest of our patients for us to really work together to create OT specific guidelines and parameters to support what we can offer the kids.
And do you find that nurses or physicians are open to that, to at least working with you to make sure that the kid is safe, but at the same time, a lot of times occupational therapy is the best part of their day. I know we're biased in saying that, but
Yep, and I think being loud to the medical team, nurses, doctors, physician assistants, being loud about how great our services are and all the good that we can do and the potential there is if children um, engage as much as possible. So in my experience, I developing partnerships with those other people on the team, simply learning their names, having just making an effort to interact with them and close the loop back with your referral source. So getting a referral from a physician, they may not fully understand what you're even going to do with the child, but they trust that you're the expert in helping the child, gain their functional abilities back. So I just think absolutely include. I mean, we have to in order to we have to include them in those types of decisions. But sometimes it needs to come from us because we have a better understanding of what a child is able to engage in based on lab values and so on. So
great. And I think especially in the midst of COVID, where we are really trying to work so cohesively as a team, and maybe it's helping to put a kid back to bed, or getting them out of bed, the things that sometimes, especially right now, that nurses are overworked to the point that anything we can do to make their life easier, suddenly they're going to be more interested in helping us as well, probably. I don't know if that's been your experience, but it's always been mine.
absolutely, we've got to work as a team. Got to work as a team. And I also find it's helpful to really make an effort to see exactly how we can shift our day to support nurses and other allied health professionals, and just make an effort to say, hey, what's on your agenda for today for the kiddo that we both plan to work with? How can I schedule my session with this child to make your day easier, to make it more effective for the child? So got to be a team.
So obviously, our aim is always to use a standardized assessment as much as possible, but sometimes there's going to be barriers that get in the way of doing those standardized assessments. Do you have any recommendations on what we can do to try to get those in there, or kind of maybe best practice in terms of balancing standardized assessments with some of the productivity demands we find ourselves with?
I think, and this has always been sort of a frustration of mine because it is time consuming, and it does feel like there are so many barriers to using standardized assessments in acute care for children. But I think recently more types of screening tools are being published that are age appropriate for a broader scope of clients that we work with. Also, there are more focused assessments available on different conditions. So thinking of client factors. So one, delirium assessments. There's a broader scope of delirium assessments that are absolutely appropriate for OTs to use that are meaningful in the acute care setting. Also, the Pediatric Quality of Life Inventory is a great screening tool that has condition-specific modules that can be used more of a screening tool to see if it's appropriate to and necessary to kind of get other disciplines involved as well to meet a child's needs as far as health-related quality of life. But I just think there have been many new standardized assessments that are more appropriate for the acute care setting. So I would recommend making sure to have a broad scope that addresses, very young children up through adolescent. It's with the adolescent population in pediatric hospitals, they're often kind of lost in the mix, and that's not an OT specific issue. That's I think, healthcare system issue. And these adolescents that are used to being part of these pediatric health systems for years and years, especially those who have chronic and critical chronic conditions, they often just, they can often get lost in the mix. And so it's so important to provide and utilize age specific standardized assessments intentionally to meet the needs of very young children up through adolescents and young adults.
Yeah, it's funny you say that. The most used book in our profession, at least in academic settings, is Occupational Therapy for the Child and Adolescent. So it's now Case Smith's Occupational Therapy for the Child and Adolescents. And it was because kind of figured out that there are adolescents as well, not just children that we're working with. It goes across settings, certainly. So in terms of, we talked a little bit earlier about teams and the interdisciplinary team, the interdisciplinary approach. What kind of recommendations do you have for OTs to help facilitate that good collaboration among teams? And in a pediatric hospital, what are the other types of members of the team that you're likely to run into?
In my experience, I've worked very closely with child life specialists, and I think they just have these superpowers, an amazing way of meeting children and families where they are. And they're fantastic at providing age appropriate and timely descriptions of procedures that need to happen or information about a medical condition that a child can understand. And within the course of, occupational therapy treatment, they can also be really helpful in from a motivational perspective, helping to partner with the therapist. So I think that, the philosophies of child life and OT overlap and complement each other beautifully. And it just makes for a really great, effective partnership and setting a child up for their most successful day and, establishing a routine and establishing a schedule, getting all hands on deck in a way, to organize a child's day that is the most helpful for them. Also, nursing, we have to partner with our nurses. And so I think it's important to, when possible and when time allows, reach out to the nurse first thing in the morning of your day if possible, and just out of respect of their time and the family and child you're working with, try to schedule as much as possible. And also partnering with nursing to figure out which medications we need to schedule our OT sessions around. And that could change on a daily basis, especially in the PICU setting. So I think partnering with nursing to help get a clear picture of what the child's needs are from a medication perspective is really helpful. Respiratory therapists, I love working with respiratory therapists, and I know they are busier than ever. And yes, but as far as, the emerging early mobility programs in both PICU and NICU settings, respiratory therapists play a critical role in bringing those programs to life as well. So, but I think at the end of the day, just recognizing the unique value in other professions and helping them to understand the unique value we can offer as OTs and how that looks differently, and how that differs between patients. So, for example, the needs of a young child admitted to the hospital for a stem cell transplantation will have very different needs and expectations than a child admitted to the hospital for spinal cord injury or near drowning, whatever it may be. So just recognizing and helping to other professions understand what we can contribute, and then making it evident that we appreciate what they can offer too.
Yeah, how about those pesky physical therapists and speech language pathologists that we tend to do a lot of co-treatment with? So you want to talk about some of your experiences with the other members of the Tri Alliance? Did you know about the Tri Alliance?
Yes.
OT, PT, and speech.
I did.
It's very exciting.
Yes, it is. And I think I didn't mention them because it's a given that we work so closely together. I love our PT and SLP friends. So in my experience in the PICU, I've worked very closely in collaboration with physical therapists, especially in the early phases of mobilizing children after either complex procedures or accidents for a variety of reasons. But it is a great way to be, safe and effective the first, couple times that you work with a child who is in very critical condition. And of course, we're always partners in working with and establishing a consistent plan from a rehab perspective with medical care providers as well.
Gotcha. Did you do much when you were in New York with dysphagia with speech language pathologists, or how did you negotiate that?
We did. So in New York, when I worked in early intervention and pediatric skilled nursing, our speech language pathologist definitely took the lead on that in the settings that I worked in. And depending on the child and their needs, OT was of course on board more to address the self-feeding component. But in my experience, the places I've worked in New York, the speech language pathologist definitely address that. Also in the acute care setting, and I know that's very different between hospitals. In my experience, in the acute care setting I worked in New York, we had, oh my gosh, between 30 and 40 at least at the time, occupational and physical therapists combined, and only three, I think, SLPs at that time. So their primary focus was really, assessing swallowing and addressing those issues in that environment.
Yeah, so it's good to have those friends, especially when we're working on feeding. And there are, there are some regional differences with dysphagia in terms of, even hospital to hospital. Sometimes, the OTs can take a lead or just, be close collaborators with that speech language pathologist, because especially with a lot of these really young children, and folks with developmental disabilities when they're younger, especially, positioning is such an important piece of keeping people safe. And so, the better we can work together, hopefully the better outcomes that the kiddos we're supporting are. Do you use the word kiddo?
I
Is
do.
that pretty
I
common?
do. I might have even typed it in my notes. I use
I,
it all the
yeah,
time.
do you call your own children
Yes.
kiddos?
Yes, I do.
Okay. All right. That's good. I like the word kiddo a lot
I do
as
too.
well.
I do too.
So any advice? So as part of those, relationships with our OT and, or I'm sorry, our PT and our speech language pathology and our nursing friends and social work friends, any tips you have in terms of just trying to foster that really strong relationship and partnership between the different disciplines?
I think just avoiding unnecessary silly turf wars that are just silly and really establishing a partnership with the other disciplines and the families and other medical professionals that we work with. I think keeping the lines of communication open with other disciplines and your referral base is really important. Um, and just it's going back to therapeutic use of self, and that may sound silly, but it is so critical in being intentional, I think, with our interactions with the kids and families we work with. But we need to use, I think, that same approach to other disciplines, because different disciplines have different needs, and different amounts of time and different times of the day are more helpful for certain people to have conversations than others. So I just think being respectful and intentional and mindful about that can be really helpful.
Yeah. So one thing that always has been just something that when I had students, they would bring it up to me on a ongoing basis. So when you have a physician that does a referral for occupational therapy that might say something like, please keep this person occupied. Like, how, how do you respond to that in a way that hopefully is educational for the physician and potentially helpful for the patient that we're wanting to support?
So I sort of gently nudge or offer, actually, it's a bit more than just keeping someone busy. And I just, sort of respectfully offer a little bit more information about what we are setting the child and, family they referred to us to do. And so I try to be intentional with offering specific information and specific activities guided by occupational therapy that are very unique and sort of distinct from other professions. So always emphasizing that our role is to teach children and families to be empowered, advocate on their own behalf, and participate. So it's not doing things for someone; it's encouraging them to do it independently. So I think sometimes the individuals referring clients to us need a reminder of that as well. That it's more than just keeping somebody busy.
Yeah, but I think sometimes like a doctor is well intentioned and it really is within our scope of practice. So like if they're looking at, restraint reduction or something that's really important, I think we do have a strong role that we could play. I don't know if you've had any experiences with those types of situations.
Definitely, definitely. And I think too, it's helping um, physicians and nurse practitioners understand the direction that we focus on when working with children and families. So, in New York, when we were in a time of very quick and rapid development in the pediatric oncology program, one of the attending physicians was a huge support of the rehab department. And if he had it his way, I think he would have rehab and, working with kids every single day. He would always say, Laura, you need to go see this person 8 days a week for occupational therapy. We got to get him up. And, before sort of this culture shift on the floor, there was this underlying expectation that, children, and I'm speaking in generalities, that's not a general consensus, but there just wasn't, when there wasn't a strong rehab presence, the expectations were a bit lower, even on the from the perspective of, physicians and other medical professionals. So there was this expectation that, if a child was admitted for a very, very, very prolonged amount of time, they would probably, the day they were discharged, need a wheelchair to leave the pediatric unit. And so, sort of after this shift in, and this took years and years and years, but what we saw was that once rehab was part of a consistent routine, and there was this a shift in expectations of what everybody expected of the children to be able to do, families, nurses, doctors, other professionals, we got to a point where that same attending said, you know what, since there has been more of a presence of rehab on this floor, he said, these kids, the day they're discharged, they don't need wheelchairs to leave the unit anymore the day they're discharged. And that just was so eye-opening and exciting for me. But also I'm like, we need to write that. We need to put that on paper and publish it. And there need to be, we need data behind that. So I think, there are a lot of conversations that are being had, but we also need to get a lot of this on, published in collaboration with these physicians to really articulate the benefits of everything, because we see these great things every day.
Could you talk a little bit about COVID and maybe how that's impacted sort of pediatric hospitals? I know that for a long time, even at Cincinnati Children's, we certainly had COVID patients all along, but sort of with this most recent wave, it seems to have gotten much worse. Fortunately, the numbers have come down a little bit again, but can you just talk a little bit about that and how that's impacted hospitals?
Sure, sure. So, from my clinical experience recently has been, I'm actually back at Home of the Innocents in a per diem position now that I'm teaching full time. So my perception during COVID was as a PRN therapist, and just, sort of during the thick of it over the last couple years, those things that we talked about during the beginning of our discussion, things like social isolation, and just some of those common barriers, I think those are just escalated. And unfortunately, and with the limitations on staff availability and limited support, I think that's compounded the issues that were already present and that children and families were already dealing with. I think at this point, now that some of the restrictions are being lifted, that the weight can feel less heavy, but I think we're going to just now start to see some of the true trauma that occurred, and it's going to manifest in different ways for children who are hospitalized. And, I think we'll even see that in the school-based practice as well. But I think the trauma that occurred during COVID and that continues now, that will become more and more evident over the months to come, I think. So I think OTs in hospital-based settings will have a really important role now and in the near future to really make an effort to recognize acute stress, signs of acute stress, and have a good handle on what referrals to request and how to support families.
And AOTA's come out with some nice resources, right?
They have. So I believe I mentioned addressing acute stress and trauma. A decision guide for COVID-19 is available on their website, and they have a couple others as well. And there are some good publications. A lot of it is in the adult literature, but that's kind of true of everything, right? Pediatric literature is always, we're kind of catching up. But I think, the multi-system impairments from COVID are well documented. So as practitioners, that's something we want to always be mindful of. And, COVID manifests differently in children, and the evidence is growing to really help us understand what that even is. But I think there are some really solid resources available to help provide therapists with direction on what to just really keep a close eye on right now.
Great. And those will be listed in the handout that you can get from occupationaltherapy.com as well. Can you talk a little bit about things that occupational therapists can do to help ease some of the burden that families experience and kiddos experience when they're looking at the transition? in care when they're going from one setting to the next or from the hospital to home, those kinds of things.
Yes, and I would love your perspective on this too, because I know
Sure.
this is you have a lot of experience in this. I would love your perspective on everything we've discussed, but I know this is an area you have a lot of experience in. So I think these easing the burdens of transitions in care is a great place to position students to build programming. So um, helping support families, depending on what their issue may be, there may be a medical reason that they need to continue to bring the child to that same hospital for rehab. So there might be benefits in keeping all of their care in the same system. There might also be great benefits by moving their care, occupational therapy as an example, to a community-based setting. So the child can become more comfortable and the family can become more comfortable, kind of loosening the ties with that hospital-based setting that's kind of been a security blanket, for children with chronic or critical issues for a long time. So I think it needs to be a team decision, when and where a child receives, therapy services specifically, but I think students can be positioned to create really exciting programs and fill some gaps in those transitions. I think it can also be helpful for a formal liaison to be established for families to kind of maintain the connection between the hospital-based practice and school-based practice and the family. And when we think about pediatric communities, kids are they can be part of so many different communities. If they're on sports teams, if they have families that live in different areas, if, their school is far away from they're just associated with so many different communities. And I think it can feel really overwhelming for families to find common ground. So to have somebody who's established as a formal liaison to take on that role that's not the parent can be really helpful.
Yeah, absolutely. So you're right. Students are phenomenal at that. It's sort of like they do a really nice job specifically at creating programs, but also compiling resources so that, maybe they've got handouts a little old school, but if you have access to your hospital's webpage and can even, maybe create some discharge resources potentially, obviously those can be printed out or included in their medical record as they're leaving. But, especially like some of those connections like you talked about with community-based resources that are going to help support their engagement in occupations that other kids that maybe are not struggling with some of the issues that they're struggling with have access to. At Cincinnati Children's, we're really fortunate within our program we have, or within our department, we have two. Obviously, social workers are kind of everywhere within a hospital system, but we have two specifically. They're not social workers; they're actually kind of vocational rehabilitation counselors, although they deal with all sorts of transition issues. But they're really experts at knowing what resources are out there, specifically looking at developmental disability, vocational rehabilitation, and then working with those school districts so that kids, if they need an IEP, if they're coming off with some significant restrictions, or maybe they're immunocompromised and can't go back to school and need to do some remote stuff, how do we help support them so they can be successful until their immune systems are back to the point that they can return to school. So that would be, I don't know if that was what you wanted or not, but that's kind of what I've seen. And again, students can just be great at that. I love Costco. Here's the relationship to Costco. So apparently people love Costco because it's sort of like the right level of product that you need for what you want to do. There's not 10 different like lawnmowers. There's one lawnmower. They've done the work to figure out what the lawnmower is that most people need. And so in some ways, like a student can be sort of like that when they're creating resources or finding resources. If you just have something for a family, a parent, a family member that's kind of overwhelmed and can't just go to the Google machine and just look at everything that's out there. If you have somebody that's kind of curating it a little bit, students, that could be the new role for students. We're creating curator occupational therapist. Maybe that's the new frame that we can use.
Absolutely. I would love to share one example of an idea one of our students brought to life during her capstone experience. She worked in an outpatient setting at a pediatric rehabilitation hospital, and her focus of her capstone was to maximize leisure participation for children after being discharged. And she had an interest in learning about trauma-informed care and addressing specific issues related to physical trauma as well as emotional trauma. So her project, she created an interactive map for children and families to use when they were discharged from this hospital. And within this interactive map, she created sort of a key and resources that gave families information about: was the site accessible? What age children was the site appropriate for? Were there times of the day that the site was less busy for children who are immunocompromised compared to busier times of day? And if the site was accommodating to families, if they needed like a private space. So it was incredible to see her bring all of these ideas and create an interactive website where families could actually click on different places that were on this, map around the community. It was really exciting.
I just think students add so much to most of what we do, and so they're great potential resources. Any other ideas in terms of capstones or these OTD doctoral students and things they might be able to do to help you in your everyday practice?
Another idea that I saw a student bring to life was just incredible. So this was a student who's very interested in working in pediatric oncology, and this was last year where it was, very difficult to find a collaboration where a student would be positioned to actually work with children in active treatment or even post-treatment. So this particular student had experience as a dancer, and she was a dance instructor. And so she created a program that allowed, it hasn't actually been used, but I think, that'll be next to come for her, I hope. But she created a program that is accessible to children admitted to the hospital, and she created adaptive dance classes. So her goal was to meet the needs of children admitted to the hospital for cancer treatment with very specific issues. So for example, she tailored a dance class appropriate for preschoolers that were not quite strong enough to stand at the edge of their beds. So the adapted dance program was designed for these children to participate in a choreographed routine sitting at the edge of their bed, with supervision, of course. So that's just one example of how students are being creative and creating resources for children who are hospitalized that they don't necessarily have an opportunity to directly interact with. So I'm always blown away with the ideas students come up with. It's so fun.
Absolutely. That's kind of the fun part of teaching, and part of what I miss. And I have an affiliation with the University of Cincinnati, but no real strong teaching responsibilities other than these capstone students. We had during COVID, we had a couple of capstone students, and one of them actually was really responsible for our return to work PPE curriculum that we did in terms of helping young adults with intellectual and developmental disabilities kind of figure out the importance of PPE, and even created some videos and supports to help them understand the necessity of it and how to even don and doff it. So by the way, every podcast we will say the word don and doff at least once.
We have
and
to.
three jaw chuck is my other.
Yes.
That's the other one. I'll try to see if I can get that thrown into here at some point. So still have a few minutes left for that. So in terms of recommendations, maybe for that student who's graduating, or for maybe an occupational therapist that's looking to change settings and to go into a pediatric hospital, I always found as a fieldwork coordinator, it was probably the trickiest of all the settings in terms of looking at placements for students. So any advice you might have for the student going in or someone looking to change careers a little bit as an occupational therapist?
My number one recommendation would be to establish a mentor. If you can find someone in the field that can offer you resources, either locally or in whatever capacity would be helpful. But I think finding a mentor who is a seasoned therapist in the practice area of your interest, that would be my first recommendation. For students, if they're living in an area that, there may not be as many available positions in pediatric hospital-based settings, I usually recommend that they try to get one foot in the door in some type of PRN pediatric position elsewhere so they can work on their pediatric specific skills. So that may be early intervention, it might be part-time in a school-based setting if that's an opportunity, and then the other foot in the door working with in adult acute care. So combined their experience in pediatrics, and then even if it's working with adults in a medically complex setting, it can help them gain an appreciation for and the confidence to work with children eventually in medically complex settings. So also, I think there are a growing number of AOTA fellowship programs in pediatrics, and I think these are so exciting, and I'm totally jealous that these were not an option many, many years ago when I graduated. But a couple examples include Boston Children's Hospital of Philadelphia, Cincinnati Children's Hospital Medical Center, just to name a few. You've heard a lot of great things about that one, right? Maybe you can tell us a couple things.
They're wonderful, and you're right. They're great experiences. Nationwide Children's also. So we have a lot of great hospitals, children's hospitals in Ohio. So we're very fortunate in that setting. But yeah, it's just a wonderful part. The way that works is that 75% of your time, 80, 75, a large percentage of your time is really in treatment, and then 25% of the time or so you're devoted to research types of activities. Usually there's some affiliation. Well, I think there has to be an affiliation with the university, so you get a little bit of practice teaching, and not that we necessarily want everybody to be able to hit a lecture spot on, but it really is. Whenever you teach, you have to think about what it is you're doing. So yeah, I'm with you. Residency I'm much older than you are, so we're way beyond the thought or the pale when I was coming out. So no, I think those are great ideas. Any ideas on how to find a mentor?
I would, what I did, I mean, I picked up the phone and called a couple places. I did. And especially when I was new to pediatric oncology, I literally picked up the phone and called other uh, cancer hospitals. And I said, my name is so and so. I work with this population at this place. I would love to share ideas with someone who works with a similar population. So old school, pick up the phone and call. Also email, but there's so much information available that is easily accessible. But that would be my recommendation.
I was thinking AOTA as well. If you go to the national conference, it's just a great way to meet people. And so the key is not to be the first one in line when you're talking to a speaker, but to be the last one in line, and then they can't run. Well, they'll try. They'll say, I have another meeting, I have to go, and then just follow them. No, don't do anything creepy. But, I think it's a good way to meet some of our national experts. And I remember, being, when I was a student, that, you would have these people on pedestals, and, most OTs are really kind, warm, exceptional human beings. I mean, there's a couple that are not, but most of us are really good people. So AOTA is a really nice way to meet those mentors as well. And also would have, if maybe it's an academic and not a clinician, they probably have some clinicians that they can refer you to as
I
well.
was just gonna say I've had a really fun opportunity at our university here at Spalding to create a pediatric critical care elective course for our students. So for students we have a specialty topics course where students can choose a couple areas that they're interested in depending on faculty availability and expertise. So I know here at Spalding, in the creation of that course and other specialty topics courses, we really make an effort to involve guest speakers from other universities, other hospitals, other institutions. So I would encourage students to reach out to those guest speakers that are introduced within your courses on topics of interest too. Don't be afraid to, follow up via email with additional questions and ask for them to offer any resources they may be aware of.
Great. I have great ideas for other people. Do you invite clinicians to attend any of your courses for their own learning? So that might be a nice little way to do that, and see if you can offer continuing ed or something like that, and have them maybe in the evenings when clinicians would be available. In all your free time. That's what you could do. Yeah, just in all your free time.
I
But
love that idea.
something to think about. Well, I think anything we can do to kind of cement the academic and the clinical aspect of our profession, because we all get along typically and like each other. So anything we do to facilitate would be great. So in terms of that, any other recommendations for people as they're maybe entering pediatric practice, the things they can do to help navigate the complexities of that acute care setting?
I think just uh, being intentional with trying to, balance the operational demands of hospital-based practice and remaining true to the occupational roots of OT practice. And this is a really hard thing to do, but I think if you can just prioritize always going back to the main occupations that children engage in, play, make that a priority in the hospital. Have fun, create fun, and I know it can be a really overwhelming place to make that a priority, or really bring that to life and make it happen. But I think always keep that at the forefront is just find meaningful, enjoyable things for the kids and families to engage in. They're also really AOTA published, the acute care textbook is fantastic by AOTA Press, and they have some really great survival tips that are posted or published in that textbook as well. And just always keeping practice guidelines accessible and current. And again, these might be practice guidelines from other professional organizations or standards published by other institutions, or they might be department specific. So just whatever those are, keep them readily accessible so that you can spend the majority of your time focusing on other things instead of digging through just many resources. So staying organized, I think, is key.
Can I give a practice guideline tip?
Please.
So they publish a piece of them in AJOT. So if you, like any practice guideline that is there, typically there's a form of it that's an AJOT. So, it's nice to have that access to that as well. And that way, when they do update it, usually there's an update in AJOT as well. So nice way to, little tip for those playing along at home.
Definitely.
And so as we are winding our time up, it's hard to believe it's been almost an hour. But can you just maybe give some final advice for practitioners that are really interested in pediatric hospital, or things that we can do to help make the world a better place for kids that are, and therapists and nurses and other members of the healthcare team within those pediatric hospitals?
I think OTs are really well positioned to remain focused on the big picture and just maintaining human connections, I would say. And so this goes, I think, between OT practitioners, maintaining a connection with the kids that they work with and their families, and taking a holistic top-down approach rather than getting, hung up on sort of the skill-specific issues that I think are so often emphasized in acute care. And I think just using therapeutic use of self is everything. And so I think it's important to remain cognizant and to be intentional with your interactions, not only with the clients we work with, but also with the people we work with, doctors, nurses, other health care professionals, maintenance, housekeeping. It takes all of us to support the kids and families we work with in the fragile state that we often meet them in. And I think in the acute care, pediatric critical care settings, we could be working with a patient on their lowest day, and just to remain positive and hopeful, I think for them is key, and everything else will fall into place.
Yeah, I think you're right. I'm old, so I remember someone once said to me that it's important what we do, but patients rarely remember what we do, but they remember how they felt. And so what are the things that we can do to really help them? And sometimes we have to support kids, as you said, that are in pain or having a rough day. But how do we do it in a way that kind of upholds their dignity, in a way that kind of supports them so that, we can be with them on a rough day, and hopefully tomorrow is going to be a better day for them. So Dr. Laura Stimler, I'm from Spalding University in Louisville, Kentucky. I really, this time has flown by. So thanks so much for your time, and I hope you have a great day.
Thank you so much, Dennis. I really enjoyed our discussion. Thank you.